Good evening. We wait for the people to join the Zoom meeting and we'll start in 30 seconds. I see the number of participants is expanding. As soon as we reach 100. Okay, this is perfect. So good evening. My name is Morgan Rouprey. I'm a professor of urology at La Pitié-Salpêtrière Hospital, Sorbonne University in Paris, France. I hope some of you were at the EAU in Paris a few weeks ago. I'm still there alone, but surrounded by a superb European faculty tonight with Professor Widges from Radboud University. He has been the chair of the muscle-invasive bladder cancer guidelines, but he's also a top expert in non-muscle-invasive bladder cancer. And we have also on the line Dr. Prader from Toulouse, La Croix-du-Sud. He's also a top expert. He has spent a lot of time with Sharok Shariat. He's involved in the UROonco platform, member of the panel of the guidelines, the European guidelines and the French guidelines on non-muscle invasive bladder cancer. So I'm super happy to trigger a debate, which is highly interesting because you all know that there is a lot in the field of bladder cancer at the moment. The pipeline is very rich. New drugs are coming, new kids on the block. But the reality is that we are seeing a lot of non-muscle invasive bladder cancer and also low grade. And we believe that today the surveillance regimen is much more eminence-based than evidence-based. So the question today is whether or not we are in a situation to decrease a little bit what we do in low-grade non-muscle invasive bladder cancer in terms of strategies, what we call de-intensification. So is it ready for prime time? Do we have a sufficient amount of tools to, I would say, decrease? This is very important to see what is reasonable and see what is feasible. And from the beginning, we'll start right away with Benjamin Prader. He will defend the position we should stay as it is. So it's a no in his mind. And then we'll switch to Professor Widges. So Benjamin, the floor is yours. We are listening to you. And you have already 162 colleagues connected. And before you start, I just would like to let you know that you can use the chat of the Zoom to submit your question as it is mentioned already in the Zoom. Welcome to this webinar. Please submit your questions through the Q&A. We will have some time for discussion at the end of the presentations. So Benjamin, we are listening to you. Thank you.
Thank you very much, Morgan, for the introduction. I'm very happy to be with you today and to present this webinar. So let's drop my slides. I think normally, oops, it should work. Now, okay. Yeah. So I have to present the part where I have to explain you that finally strategy for de-intensification is not ready for prime time. These are my conflicts of interest, but the main one for this presentation is that probably my practice tends to be in favor of de-escalation, but somehow it needs to be understood that it's not ready for prime time right now. First of all, we are talking about low-grade disease, but low-grade disease, as diagnosed by our pathologist, is not so well diagnosed. When you look at it, the general conformity between two pathologists in the grading is only of 50%, meaning that probably we miss a lot of tumors and grades and high-grade tumors when we ask to our pathologist, and especially when it's not a uropathologist dedicated to urology. So today, the grading system and the way it's graded by our pathologist still needs to be improved in terms of reproducibility. Therefore, we are probably missing some high-grade tumors among our low-grade. So low-grade disease is still a very hard entity to define by the pathologist. So finally, why don't we go for the sexy urinary biomarkers that we are all talking about? Well, when you look at the urinary biomarkers that are available today, the data remain very weak. and there are strong bias, especially when you look at the condition and the therapies that were administered to the patient, the population that were included in the different cohort and in the different studies. The follow-up of these patients in these studies is very, very short, and you have a very lack and poor data when it comes to low-grade non-muscle invasive bladder cancer.
And Ben, shouldn't you forward your slides? I still see your first slide.
You see? Oh, okay. You still see my first slide. That's not good.
The screen is frozen, Benjamin.
Okay. From where are you?
The title.
Okay. Oh, that's fantastic. Maybe we can have some help from Hannah. Let's see if I can try again, and you let me know if it works. Is it working now?
Now it's working.
Fine.
Okay. Oh. If it's working now, that's perfect.
Okay.
So I go back to the slide where I was telling you that low grade is not so well diagnosed with a reproducibility that is not so good among pathologists, with only 50% in terms of grading, which means that we can miss some high-grade tumors. And so finally, the question was, why don't we go for these urinary biomarkers that we all talk about? Well, the data remain really weak. We have strong bias. The follow-up of these patients is really limited in the studies. And especially when we talk about low-grade non-muscle invasive bladder cancer, the data are quite weak and very few. So we have a very low sensitivity for low-grade recurrences. And even the best studies that are the recent ones just have a sensitivity of 40% in low-grade disease. So for low-grade disease, so far, urinary biomarker are not to be shown as a prime time tool for the diagnostic. Therefore, we are now looking for new data and new studies that are enrolling patients, especially in low-grade disease, to improve the diagnostic test capacity of this biomarker. But so far, we don't have enough data. And also, regarding urinary biomarkers, we still need data regarding the cost of it, the impact on healthcare, the ease of use of all of these biomarkers, because some of them are quite difficult to use on a daily basis, and also the patient acceptance. Therefore, when it comes about urinary biomarkers, I think the best is to follow the guidelines. And the guideline says no urinary biomarkers can replace cystoscopy during follow-up or lower cystoscopy in a routine fashion, meaning so far it doesn't make any sense. So finally, we are talking about low grade, but to which risk stratification these patients belong? When you look at the EAU guidelines table for risk stratification, of course, these patients belong to the low risk. But most of the patients do not belong to the low risk stratification group, but to intermediate risk. But when you look even in high-risk patients, low-grade disease is also included in high-risk patients. That means the risk stratification helps us to treat the patient. So we really need to be careful and to not accept that low-grade disease is a low risk. So low-grade does not mean low risk. It mainly means intermediate risk, and sometimes even high risk, according to the EAU guidelines. And so when you look at the intermediate risk, and I voluntarily do not use here the EAU guidelines, but the recommendation from the intermediate risk classification from IBCG, you see that the treatments for these patients is not so low. It means, it's not a small treatment. For most of them, intravesical induction chemotherapy is recommended. BCG might be used. So therefore, most of the patients that we have in intermediate risk, which is the most of the low-grade disease patients, have one or two risk factors, or even more, three risk factors. And for both of them, the treatment is much more than a single instillation. When we talk about the diagnostic and the initial therapy, are we good enough for low-grade disease? Well, we don't need maybe urinary biomarker. When you look at this very interesting study where they asked the urologist to assess the tumor, you see that for more than 85% of the tumor, the urologist is able to correctly define low-grade disease. So low-grade disease is well defined by what? By a cystoscopy, not by the rest. So that makes sense to continue to do cystoscopy. And for the treatments, we know that the recurrence rate, which is the main impact of low-grade disease, is quite high unless you do a good TURB. The TURB decreases the recurrence rates from 45% in multiple tumor to 7% if you do it well. And this is exactly the same with single tumors, with a high reduction in terms of recurrences if the TURBT is well performed. So a good treatment remains a TURBT. And for the TURBT, you have a lot of tools that you can use to improve it, actually, especially for TA tumor. When you look at the data, right now, the residual tumor for TA low grade are visible in 56% of the patient. Therefore, there is still a need to use some improvement of tumor visualization when you do a TURBT. So decreasing the intensification of diagnostic remains not feasible in that moment when you perform a TURBT. What is the impact of low-grade non-muscle invasive bladder cancer? Low-grade means high recurrence. We all know that the cancer-specific survival is really good for patients with low-grade disease. The risk of progression remains low. Nevertheless, we also know that the 5-year recurrence rate is around 50% for single TA low-grade, but goes so up to 90% of patients with TA low-grade cases in a multifocal setting. Most of the factors for recurrences are the size, the multifocality, and the age, as well as the aspect of the tumor. But when you look also at the recurrence of these patients after 5 years, it's still 13%. That means the recurrence is really the main issue and the main problem for us as a clinician. So basically our treatments and our diagnostic needs to be as good as possible. And also this disease, the TA low grade, impacts much more the patient than we think, especially because of the recurrences. So if we have a lot of recurrences, we increase the cost of this tumor, especially regarding the recurrences. When you look at it, the low grade are one of the most expensive one according to the recurrences. And when you look at this study that was performed in US, where the management is a bit different, you see that there is an overuse of surveillance modalities, which means more than just a cystoscopy. And when you look at it in the last 10 years, the annual median cost of low-grade TA increased by more than 60% for anyone. So low-grade disease has to be well treated, and we should use the more accepted treatment and the more accepted diagnostic way. When you look at low-grade recurrence, the most important part is to check and to assess the index tumor. As I said, most of these tumors are intermediate risk or sometimes high risk, but intermediate, meaning they are recurring a lot. So the main point remains to check what was the index tumor, because the way you're going to treat it and the way its risk to recur again and to progress is very different. Indeed, when in this study driven by the team from CAMAT, patient with a low-grade index recurrence was still estimated to progress at 5 years after BCG treatment in 14% of the cases, meaning the progression rate of patients treated with BCG and have low-grade recurrence will progress in 14% at 5 years. That's a lot, and that needs to be to take in mind when you decide about the treatment you want to give to these patients. Of course, the immediate single instillation for all this low-grade aspect is necessary and is recommended by our guidelines. So basically, this is much more is of utmost importance to always propose post-operative immediate single instillation, as it has been shown in many studies that is the recurrence rate is reduced by 14% in these patients. So this is the main treatment when you see a low-grade patient, and this is for low risk. When you talk about de-intensification, as we mostly talk about intermediate risk, that means the treatment still to stick to the guidelines. So low grade does not mean low risk. It means most of the time intermediate risk with intravesical chemotherapy or BCG, according to the index tumor most of the time. And basically, when you look at the predictor of this tumor and about the predictor of progression and recurrence, the main predictors are multifocality, tumor size, and the tumor aspect, sessile versus polypoids. And when you think about it, how can you assess multifocality? Not with a urinary biomarker. Potentially with some imaging, but still it's very hard to see if there is real multifocality. Most of the time you see the main tumor. Assessing size might be done with imaging, but never with a urinary biomarker. Tumor aspect can't be performed accurately with imaging, with our actual imaging, or with a urinary biomarker. Therefore, this is the main predictors, and these predictors needs to be assessed by what? A cystoscopy and a urologist. So the new innovation, the de-escalation, does make no sense for these patients because you need to see if there are predictors of recurrence and progression. Are there other treatments for these patients? Of course, you have some options, but options only for active surveillance and fulguration. There are no strong evidence, especially for active surveillance, where it's mainly based on retrospective monocentric study. And for fulguration, there is one randomized clinical trial that show an interest for fulguration, but still it's a small cohort. So basically, follow the guidelines. Do not use active surveillance or fulguration as the main option, as the main treatment, but only in very selected cases as an option. And chemoablation. Chemoablation is a very attractive new way to treat non-muscle-invasive bladder cancer. And the DABLACA13 published last year was the first to pave the way of a new strategy for non-muscle-invasive bladder cancer. But when you look at the recurrence rate, which is really impacting patient healthcare system and the way we treat the patient, no difference. No difference between chemoablation and what we usually did, TURBT plus instillation afterwards. Therefore, what to do chemoablation? Finally, when you look at the proportion of patients in both groups in the DABLACA13, you see that there were a high difference in terms of relative difference in patients with more than 8 tumors, so high multifocal, which were much more frequent in the control group than in the intervention group. And it was an open label study. Of course, this is the best one, and I will not criticize it too much, but take into consideration that chemoablation is just not doing better. So not ready for prime time so far. Should we change the surveillance of our low-grade tumor? Well, actually, when you look at the new EAU guidelines published this year, we do not do so much. For low-grade disease that are in intermediate risk or low risk, the cystoscopy and the imaging has been decreased. There is no systematic imaging for these patients. Still, the cystoscopy remains of utmost importance. But as we said, more than 14% of patients will recur after 5 years. And most of the patients will recur, 50 to 90% of the patients will recur during the 5 first years. Therefore, there is still a need for these cystoscopies. Follow the guidelines and use our template for surveillance. At the end of the day, as a take-home message, I would say that first of all, do not consider a low-grade tumor, as a low-risk disease. Low-grade tumor does not mean low-risk disease, and it's very important because most of these patients will be intermediate risk, which is a new field with a lot of new treatments that are coming, and so the treatment in intermediate risk has to be individualized to the index tumor, to see what was the first tumor and how it was being treated. There is definitely a room for de-intensification, as Fred will probably discuss afterwards, but there is still a lot of caution, and it should be proposed in highly selected patients so far. Future study will probably be better designed and will give us more room for de-escalation, but so far there is no prime time for de-escalation, and you need to follow the guidelines. Thank you for your attention.
You need to follow the guidelines for sure. But if you want to look into the future, maybe we can listen to the points of Fred Widges, because the guidelines is stating what we know. And we all know that, as Benjamin has said, there are some portion of the guidelines that are not supported by a big scientific rationale. There are a few questions in the chat, but I would propose to keep them for the discussion and to feed the discussion we'll have all together. So Fred, if you are online, we'll hide ourselves. The French are going to behind the curtain and we are listening to you.
Morgan, thank you very much. I'm going to just try to locate my own slides, because of course the title slide is the same for everybody. Well, I'm gambling now. Yeah, that's mine. That's okay. So Morgan, thank you very much for this invitation. And I'll go to full screen. I hope you can see that now. That's okay?
No, it's frozen. Now, okay, good.
You see full screen?
Yes, full screen.
Perfect. Okay. So Morgan, thank you for the invitation, also the ESU. And I have to compliment Benjamin with a very good lecture. And of course, he's, let's say, right in most of his slides, because we don't have a lot of proof or a lot of de-intensification. Certainly, if you talk about low grade. He's very right that grading is not always consistent. We heard a few presentations in Paris on the EU, and I guess maybe not in 40-50%, but a little bit less. There is some discrepancy between grading. I guess it's less when you have high grade and low grade. And my pathologist always claims that low grade T1 doesn't exist. But anyway, the second problem is, I guess, that a lot of people still do a lot of follow-up and a lot of treatment. So in intermediate risk patients, I can imagine that, but certainly in low risk. So I will get a little bit more into low risk patients, not low grade, but low risk patients. I think there's certainly a way that we can de-intensify all patients. So I looked at the European guideline, the French guideline, the British guideline, and the AOA guideline to have some support for what I'm trying to tell you. Some complex of interest, most important in this case, is for urinary markers. So Benjamin already said that the diagnosis of a low-risk tumor is quite simple. It's a low-grade, solitary, small TA and maybe pun lump. You see that if you go to the American guideline, the NICE guideline, it also has to be solitary and it has to be primary. And if you look at the EU guideline, it's even a little bit more complicated. There you have some additional risk factors, age, multiplicity, and the tumor size. And if you have only one of these, you might consider that maybe already intermediate risk, but that's still then in the EU guideline is low risk. You see that here, single or bigger or older patients, so multiple, it still is. You see that down below here. That still is low risk, although I guess you could argue that that might be already intermediate risk. In all, I think the definition of a low-risk tumor seems more or less consistent. It's a small, solitary, primary, low-grade, and there, of course, you already have the discussion, low-grade, TA tumor, and pun lump, although I guess that's very seldom. I think I see that maybe once a year, and maybe not even so much. So let's say it's a low-grade, solitary, primary TA. And the treatment, again, Benjamin has already told that to you. That's very important. You have to do a good TOR. And I guess if you do that enhanced with PDD or with other means, that's certainly something you can consider. And after that, you have to do one single shot of chemotherapy. or whether you do it the same evening or the same day or the next day, that doesn't matter. But this for sure is guideline therapy. And I think that's really very important. And you see that all the guidelines sort of gave the same advice. So again, the advice seems similar in the guidelines, a single shot of chemotherapy. And we have a lot of proof for that. You see here the older EORTC systematic review done by Richard Sylvester, a lot of patients. And you see overall, the 5-year recurrence rate drops around 15%. And it's not so much in the ones that are a little bit more intermediate risk, so more than 1 recurrence per year, or a higher EORTC risk score. And if you look at the SWOG study, where NMIBC studied single installation of gemcitabine versus saline, you see that the 4-year recurrence rate in low grade, even has a higher disadvantage, namely 54 to 34% recurrence. You see here the graph. So a single shot of chemotherapy is proven, and you know it's safe, and we should absolutely do that. There are de-intensified modes for treatment, already again mentioned by Benjamin. I think what you hear more and more, and to be honest, when I started my career in urology, already did that. It has been out of practice for a long time, but now you see it coming in again, certainly in the local anesthesia with the laser, namely in office fulguration. You see in the American guideline, it's mentioned, and in the new recommendation of the European guideline, it's even a strong recommendation. That's already a kind of de-intensification for low-grade DA tumors. And also new in the EU guideline is active surveillance, again, also mentioned by Benjamin. Is there proof for that? Here you see the French guideline, active surveillance office fulguration. I will talk a little bit later about the continuous normal saline irrigation. That obviously also has some kind of de-intensified way of treatment. If you do this instead of mitomycin, it certainly is less bothersome for the patient. And the French guideline also mentions chemoablation only in clinical trials. And you will see and hear more of that in the coming years, I guess. So is there proof for these options? Office fulguration? Well, of course, there are no large randomized controlled trials. But here you see a study by Zlotta and co-workers in low-grade, again, low-grade non-muscle-invasive bladder cancer under local anesthesia, certainly a de-intensified way of treating your patients, 270 patients. And you see that office fulguration was done a mean number of 3, and then also a number of 3 TURBTs, because sometimes the tumors were more or there was a bulkier recurrence, but still you see that with office fulguration, that is then sometimes done and sometimes TURBT. You see that the 10-year cancer-specific survival is 100% and progression-free survival is 97%. And for the Canadian situation, this was really very cheap, a lot of cost savings, obviously, because patients don't have to come in. So office fulguration, of course, is not 100% proof. In recurrent low-grade TA, safe, effective, and obviously cost-saving. What about active surveillance? You know, the Italian group by Rodolfo Hurle has already been doing that for some years, and they have given some updates on last EAUs. You see the long-term active surveillance in recurrent low risk. That's a little bit different than low grade, but still low risk. There was an Italian study. Is really safe. They had 250 patients with 130 failures, about half. And of the failures, only 1 had a T2 tumor. And of course, you know, nothing is 100% or 0% in medicine, so that you have 1 T2 tumor, of course, that is possible. And you see the treatment-free probability at 1 to 3 years is 60, 45, and 40%. And in all, let's say 2/3 of the patients, 1/3 of the patients remained on active surveillance for more than 18 months. So you still have a tumor, it stays there, it doesn't go to wild, it's not growing, or it's not going to get more. You see that are the reasons for failure, multiplicity, more than 1 lesion. But if you do well, you can stay out of the hospital for quite a long time. So again, in well-selected patients, low-risk patients, active surveillance is safe. Is it strong evidence? No, but it's really something that at least I already do for a long time in my clinical practice. What about the continuous water irrigation? There are, of course, reasons not to give a single post-op installation of chemotherapy, which is a very strong guideline recommendation. So you should do that. But if there might be a perforation, if there is allergy to mitomycin C, sometimes the logistics, are you going to do it on the OR? Are you going to do it on the recovery? Are you going to do it on the ward? So certainly for the American situation, these are really some logistics that can hinder people of getting a single post of insulation. Fear for safety, which I think we all know that it is very safe, but there are cases where you probably will not give or not dare to give a single post of insulation with chemotherapy. And then you give 1 day of continuous irrigation with water, and that's a strong recommendation in the EU guideline. By the way, I use epirubicin and not mitomycin for a single post of insulation, because with mitomycin you very often see these kinds of calcifications. They don't give complaints, but you see them after 3 months. They disappear spontaneously, fortunately, but you see that much less with epirubicin. But mitomycin C, of course, is also good. What is the risk of these patients anyway? Well, if you look at the EORTC tables from 2006, and that's of course a little bit older data set, you see that for the ones that have a recurrent score of 0, that's really the solitary small low-grade TAs, there is a 5-year recurrence rate of 31%, and if you have a little bit more recurrence score, it is 46%. Beware, this is from 2006, so without PDD, without one single shot of insulation. If you look at the US study done by NMIBC with gemcitabine, you see it's already a little bit less, 34% in 4 years. And Benjamin also showed you this study done in 2024, and you see that the 5-year recurrence-free survival in the current era is around 60%, and recurrences after 5 years are, of course, not 0, but seldom around 30%. And that's better when you do your single post of insulation. So if you don't do that, you obviously have a higher risk. And if you have a higher tumor, a bigger tumor, you also obviously have a higher risk of a recurrence. What about progression? If you look at the EORTC tables, again, you see that the progression risk is very low at 5 years. And again, this is not with current ways of treating patients, because if you look at the 2024 EU guideline, you see that the 10-year risk of progression of these tumors is only 3.7%. And again, there's always something that goes wrong. It's never 100% or 0%. So even with standard follow-up, which is cysto, cytology, TOR in case of a recurrence, the events are limited and the risks are very minimal, provided state-of-the-art treatment, good TOR, single post of insulation, and certainly a 3-month cysto. I'll come to that in a moment. So what is the follow-up? So all the guidelines claim 3 months, that's important. If you have a recurrence at 3 months, that's not good. And then if you are recurrence-free, more or less a few years every year. 9 months later, yearly. Also 6 to 9 months later, and then for 5 years every year. Same goes for the French guideline. Only the British guideline is very conservative. They say if you have nothing at 12 months, you can discharge patients from follow-up. And we've had discussions with the British people for some time, and that's predominantly finance-based, because apparently they calculated how much recurrences you will have, what the costs are of recurrences, etc., etc. And this strategy apparently is much cheaper than follow-up for example, 5 years, which from a financial point of view, of course, I can imagine. So I think mostly we could say frequency month 3, that's important. Then year 1, year 2, 3, 4, 5. And the tools that we use is cysto. I don't think cytology, none of the guidelines uses that, and no risk. And also no upper urinary tract imaging. None of the guidelines advises that in low risk tumors. How are we going to do the follow-up? What are the tools? Is that cysto, or are we going to use something else? Well, if you look at the recommendations on markers, it's funny to see the development. For example, the NICE guideline from 2017 doesn't mention markers at all. Do not use them. That's quite simple. Then you have the AOA guideline, which was updated in 2024. They already say, well, there is a limited role, future holds promise, and they only mention the CX bladder, which is available in the United States, might have a significant advantage in follow-up. If you look at the very recent French guideline, again, no marker is currently recommended for diagnosis or surveillance unless they have a very high negative predictive value. And I think some of the markers we currently have do have a very high negative predictive value in follow-up. And if you look at the EAU guideline, these are the two older ones, 22 and 23. 4 markers were really mentioned separately: CX bladder, ADX bladder, expert bladder, and the EpiCheck. High sensitivities, high negative predictive values, so they may approach the sensitivity of cystoscopy. And these 4 tests might be used to replace and postpone cystoscopy. That's certainly in de-intensification, as they identify rare high-grade recurrences occurring in low and intermediate risk non-muscle invasive bladder cancer. And this year in the guideline, it says that no urinary marker can replace cystoscopy during follow-up or lower cystoscopy frequency, but some markers have shown fairly high sensitivities to detect a recurrence, particularly in high-grade disease, and with very high negative predictive values to make the premises for their future implementation in follow-up. And these are, in the guideline, the mentioned negative predictive values. And I think they are really very good. And for high-grade disease, it's even better. It's almost 100%. So I think these markers currently could be used to tailor your follow-up and do less cystoscopies. And this is a study by Ekaterina Lautina. She has looked at all the markers. It's 1 or 2 years old. And you see if you have 1,000 patients with any grade non-muscle invasive bladder cancer, so any grade, not even the low grade, you can, with the marker, avoid a significant number of cystoscopies. Of course, you will miss some of the recurrences. That's obvious. You will have some unnecessary cystoscopies because you have some false positives, and you will still diagnose a lot of recurrences. But you can avoid a lot of cystoscopies. And I think that's really worthwhile for the patient. We implement that in my current practice. We had a problem during COVID. We were not allowed to see patients. So we started testing with the EpiCheck test because we just finished the study with that. And currently, we prevent a lot of unnecessary traveling, patient comfort, costs, by doing 1-to-1 cystoscopy and the urinary marker. And patients really, Benjamin said that patients might be afraid. My patients really like this very, very much as a strategy because, again, they don't have to travel. They have a home test. The test is sent to me. I give them a call. And if they're still positive, okay, then we do a cysto, but that's something they would have had anyway. And since October 23, these tests are reimbursed in the Netherlands. And we also looked at the financial implication. And again, you know, it's not millions of dollars, but still we can do with this strategy. We can reduce the costs with only very small delay in the recurrence of the patients, and we could reduce the costs of 1.6 million euros per year in the Netherlands. So my take-home messages, I think the definition of low risk non-muscle-invasive bladder cancer seems clear. And I have to say, Benjamin is right, low grade is not, of course, always low risk. Guideline treatment is a TOR, a good TOR, and a single post-op installation. Keep 24 hours of saline, which is less intensive, as an alternative in your mind in selected patients, maybe if you suspect a perforation. Recurrences are rather frequent, but not a threat. Progression is seldom, certainly after state-of-the-art treatment. Again, good TOR and a single post-op installation. Frequency of follow-up and the tools are also consistent in the guideline, namely cysto and sometimes cytology, but not upper urinary tract imaging. And follow-up of low risk, however, de-intensified options as active surveillance and office fulguration are safe and realistic. And in also follow-up, I really think that markers, which is again a de-intensification, will certainly replace many of the cystos that we are currently doing. So thank you for your follow-up. I think less intervention in this case certainly is more, and more is quality of life and reduced costs. So thank you for your attention.
Thank you so much. We had more than 250 people connected to listen to you, both of you guys. So I think it's fantastic to have such an audience. I'm not so sure we can have this in a room of a regular conference. So let's enjoy the virtual meeting. Less is more probably. And I think one of the experience that we had was unfortunately the COVID-19, where the patients were reluctant to come to the hospital to undergo the cystoscopies and so on. And so we were forced to, I would say, de-intensify the regimen of surveillance in those patients. Do you remember back in time how it went in those particular patients? Do you have any data from your center, Fred and Benjamin, specifically from the COVID-19 period?
Well, you know, if I can start, just like I showed on one of my slides, that was for us a reason because patients were actually not allowed to come to the hospital. And it's, of course, quite difficult to do a cysto with your Apple iPhone or something like that. We sent them the test, and the time that the patients were not allowed to come was, I think, around half a year. So that's why we came up with the strategy of a test and then alternated with a cystoscopy. And I have to say, Benjamin's right that in the beginning, patients were, well, a little bit afraid or reluctant, you know, is this good? And to be honest, I think I've been trying that now, using the data for 3-4 years. Maybe those urinary markers are even better in sensitivity than our eye on the outpatient. So patients are very happy with that. I'm happy with that. We don't miss a lot of recurrences. And if we miss a recurrence, you see it 6 months later. So for me, there is actually no safety issue with doing this strategy.
Well, in fact, there is no big deal because we are dealing with a population of patients where we are not really afraid of a progression. And if
exactly,
which is extremely little, we can still catch it later on. Benjamin, it was a pro and con debate, but at the end of the day, it's not a black and white situation. I would suggest that you come into the reality of what you think and now let us know if there is room for improvement. Probably it's a debate we had for many years in the panel of the guidelines. It is something that it is becoming concrete. The question is the choice of the marker. Maybe we can come back to that and to the experience both of you have. There are different challengers in the field. Some of them are, I would say, more efficient in the low-grade categories. Some of them have a good predictive value in the high risk, but I think the next big thing in the pipeline is indeed with what is ready for prime time is the low grade. So do you have any advice you would give for the choice of the marker that you feel is more appropriate in that particular category?
Yes, thank you, Morgan. I think this is somehow a bit hard to say because of as you said the results so far in low grade disease is not so good in terms of sensitivity and specificity than for the other ones, but still we have some good data that shows that especially if I remember well, at least bladder has a good sensitivity. So far, the best sensitivity in terms of low grade comes from a French test which use artificial intelligence and was just compared to cytology. Which called Vigilant, published in BGUI, and this was the best sensitivity test. And I think maybe the future will be the combination of the use of biomarkers and cytology or artificial intelligence analysis of cytology. And as you said, Morgan, there is probably still a need to improve the sensitivity for low-grade disease, especially in patients that we want to treat accurately, especially if they have multifocal disease. From my point of view, I don't know what do you do, Fred, but for example, for active surveillance, I will not go for urinary biomarker directly because I know I will assess with a cystoscopy and perform probably a test at that time. But I won't do in between two cystoscopy. I'm not sure if it makes sense because you're already in an active way of just surveillance and not treating. So basically, I would recommend to use this kind of biomarker at a point where you want to treat, and especially to avoid the windows of opportunity to go back to BCG or chemotherapy.
Well, I think, Benjamin, you've got a good point there. In the beginning, when I did active surveillance, because I already do that for several years, I was a bit reluctant to indeed skip a cystoscopy. You very elegantly show that we can, as urologists, very well predict stage and grade of a tumor. You can very well identify a low-grade TA tumor. But then, having said that, you also know that the chance of recurrence and progression is very, very limited. So I started doing also a marker in patients on active surveillance. And to be honest, it does well. And of course, you know that you have then a positive marker. And the beginning, I then did a cystoscopy, but not that much happens. So it's sort of, using your brain, good clinical practice. And then I think the risk is very limited. But like I told you, it's never 100% or 0%. By the way, I saw one question of the audience. If you have a low-grade tumor, you do a resection and one installation, and you have one again after 1 year, again, a small low-grade tumor. Would you still give one installation, or would you go for a course of chemotherapy?
Was it a question for me, Fred?
No, I don't know. It was a question to the panel.
I'm lost. Sorry.
I just saw that. I think if I would have after 1 year, again, one small recurrence, probably I would leave it in. But if I would take it out, I would only go for one single shot, I guess.
Definitely.
Yeah. So if we go to the question, you raised one of the point. There is one question also about the current data for urinary biomarkers. It is true that every marker has its own data, but there is no head-to-head comparison between the markers. We are in a moment in time where either we jump into the use, into practice, but the question of the reimbursement is back there, because I think it's important. We had this kind of marker in prostate cancer for the biopsy, for instance, and in France this was not reimbursed, and it was not a success at all, because it's a society where, I would say in Europe, everything is reimbursed. Maybe in the States, there is room for, I would say, this kind of marker if you have an extra cost that people can afford that with the, according to the healthcare system and their own private insurance. What is the way for you to have this marker reimbursed and be widely available on the market? Benjamin, there is an initiative in France and you will speak about it, but maybe Fred first, or how can you see the situation? And if you use it, is it at the cost, at the expense of your own institution, Fred?
So, like I told you, it's now reimbursed. And before that, it was at the cost of our own institution. We presented this as a case to the insurance companies. And if you look at it macroeconomically, it is cheaper because patients don't have to go to the hospital. They don't have to travel. They don't have to have a cysto. So macroeconomically, it's certainly cheaper. And also, if you look at your own clinical practice, so I don't have to do a cystoscopy, so I have time for something else. I can still do a telephone consultation, which also, again, gives some money. I don't have to use a nurse. I don't have to use a room. I don't have to do the cysto equipment. So if you count all that, actually, it's cheaper to do a test, even if you still have to pay for the test. But now it's reimbursed. Actually, it's quite simple. This strategy is certainly much more applicable and nice for the patient and also for the urologist.
Yeah, and so far it's true that the main problem is that the heterogeneity of patients that are enrolled in these studies, although a lot of effort have been made within the last years regarding the trials design. But as you said, Morgan, for us in France, actually, there is a huge cohort of patients that are enrolled in the surveillance of bladder cancer with non-muscle-invasive bladder cancer, and with the support of all the biomarker companies, we have built up a national data set and cohort, so the patient can get the biomarker for free, thanks to the French Association of Urology and Professor Neusier, who build up this big French data set and cohort on non-muscle invasive bladder cancer, but still we have to pay if the patient are not enrolled in a study or in a registry, as we do right now in France. And as you say, Fred, I think if you talk with your patient, and especially for patients that are not at high risk, So basically intermediate with a 1 TA low grade who recurred. I think if you tell them, listen, you have to pay 80, 90 euros for this test, and I will avoid the cystoscopy for next time. Most of the patients right now do agree after the first cystoscopy at 3 months, do agree to stay with to pay for this this kind of biomarker if they can pay, of course, and if not, we put them in the French registry for biomarker.
Yeah, I agree. So I told you we made a case for an insurance company, and there were a few men that we had to make the case. And I took a rigid cystoscope and a small plastic container, and I let them choose. So how do you want to be followed up? Do you want to have this in your penis, or do you want to pee in this small container? And they were quite convinced.
Okay.
I see one question, Morgan. So what would be the frequency?
Case. Well, which one do you see? Because I see one at the bottom, which is the clinical case. Which one?
Okay, well, one of the questions I see, how frequently cystoscopy is done on active surveillance. So to be honest, you know, I follow the schedule of the EAU. So whether I do active surveillance or a marker, the frequency that I follow is what you read in the guidelines. So month 3, month 9, and then yearly. So that in low-risk patients is not different from, and also not in intermediate or high-risk patients. So the frequency is the same.
The chat also going to touch it on the point of upper tract tumor, saying it's a urothelial disease with multifocality. If we miss, or are we in a situation also to detect upper tract with the markers at the moment? What do you think about the accuracy and the performance of the markers in that particular situation?
Ed?
Well, sorry, I missed it. I was reading a few of the questions.
Yeah, sorry. I was touching on the point of the use of the marker in upper tract, saying that we are dealing with urothelial cancer. There is multifocality, and most of the tumor are located in the bladder reservoir. But from time to time, we can have upper tract for recurrence or metachronous disease. Do you think that the markers that we have at the moment that we collect when we collect the urine are good accuracy and performance for the diagnosis of upper tract tumor?
I think that, but that's thinking. I think that might be certainly an option. Of course, there are very few data about that. On the EAU, the group from Edinburgh, Marapian, showed some of their results. And indeed, in the false positives, some of them had or a future recurrence or upper urinary tract tumor. So, like probably in positive cytology and a negative cysto, you will do more to find where that positive cytology is coming from. And I guess you will also do that with a positive marker. So that's something that the future will learn.
Okay. Benjamin, what about the daycare surgery, which is popular? We talk about the fulguration, which is safe, but for many, many years in France, we have been doing TURBT. There is also the impairment of the bladder, which has nothing to do with oncological outcome, but the functional, I would say, use of the bladder by itself after several TURBTs for low-grade disease. Does it mean that fulguration office or a daycare surgery with just the use of a laser, there is room for that? Do you think is this low-grade population? And are you comfortable to do that in recurrent low-grade patient?
I totally support fulguration, I think, for TA low grade. The main problem remains to the healthcare system you have and the institution where you are, because to get in outpatient the laser, the fiber, and everything, it means that you have a really structured your patient's pathway and management with fulguration. I mean, it's not something that you can do one day and for one patient. I think you really need to build up a fulguration strategy to get a laser, a proper laser for this kind of treatments, because you need to have the the installation of the anesthesia before in the bladder, and it may, I mean, it's still a lot of work. I would say it's like when we were talking about Hexvix and say, oh, Hexvix, you know, it's hard. You have the nurse has to come before and do the installation. I think for fulguration, it's a bit the same. You need to have a proper patient pathway to make it good, and then you have to be supported also by your healthcare system. So it depends in Europe where you are, but nevertheless, it's a really good way to avoid patient to go to the OR, to redo TURB, and as you said, sometimes re-resection may also alter the bladder function. So basically, fulguration is good, and it might be even better because you don't do a biopsy. If you don't do biopsy, if you just do a fulguration, it might be even better to combine the fulguration with the urinary biomarkers, so you are sure you're not missing any high-grade progression or something like this. So I'm completely for fulguration, but I still believe you really need to have a great structure to make it well and to make it efficient in terms of reducing recurrence as well.
Okay, Fred, is it something that you do in your daily practice very often? Ah, you're on mute, Fred.
The fulguration, you mean?
Yeah.
Yeah. Well, like I told you, when I started my training a long time ago, decades ago, we had the option of fulguration, but of course, it's a bit painful. And you know what John Palau said, it's the bzzzt technique. And nowadays with the laser, it's actually going very well. So yes, we do that in my practice for the small recurrences. You know, some you fulgurate, some you do active surveillance. It's a bit your gut feeling what you're offering the patient. But we're becoming less aggressive in admissions, TURBT, etc., in the last few years.
I think if you can do as Fred said, I think sorry Morgan, that if you propose active surveillance to patients and then you see a raising of small lesions, then fulguration might be, you know, the alternative before even going to the OR to postpone again a TURBT. You see that the patient is going to be not to be excluded from active surveillance, and you perform again a small fulguration, and he's still then afterwards in surveillance and continue active surveillance. So I think it's a great opportunity to even combine active surveillance and fulguration in this patient.
So one question going back to clinical research, but I don't know if it fits really the methodology of evidence-based medicine with its era. What would be the optimal primary outcome measure in a randomized clinical trial in the setting of replacing follow-up cystoscopies with urinary markers in NMIBC? So what would your criteria of judgment?
Well, Morgan, if we would have a clear answer, I guess that would be the Nobel Prize. Of course, most optimally would be cancer-specific survival, but that's, of course, a non-issue in these low-grade tumors. So I would say maybe a recurrence rate with emphasis on progression. You can't prevent recurrences, of course, but if you miss a recurrence which progresses, that, of course, would be, of course, something that you couldn't accept. So missing recurrences, I wouldn't be too worried about that. Missing progression, that would be nasty. Also have to look at this, whether in the future they will have recurrence. For example, one of the reasons why the Europe test was reimbursed. So you have to follow up long enough to also check the fault.
Okay, perfect.
Yeah.
I think we went through all the points, and every good thing has to come to an end. So I would like to thank Professor Widges and Dr. Prader for being available tonight. It was a very nice discussion. And also, we need to take a few minutes to say thank you to the school, and particularly Anakis, who was in charge of setting the frame of the meeting. We have gathered together more than 250 participants, which is not bad. You can give your feedback to the school if you want an evolution in the program, more bladder cancer, less bladder cancer, and also the possibility to, if you were late, to have, I would say, a vision of the whole course later on the website of the AU. So see you soon. Thank you, Fred. Thank you, Benjamin, and enjoy your evening.
Thank you, Morgan. Thank you, everyone. Have a good day. Good evening.
Thanks a lot.